Hello, future doctors. I am Dr. Salih Mhamdi, anesthesiologist intensivist at Sahlul Academic Hospital, associate professor in anesthesiology and intensive care affiliated to the Faculty of Medicine of SUS. In today's educational medical short video, I will introduce to you a very important concept, which is the damage control resuscitation. At the end of this video, any one of you should define damage control resuscitation, identify the lethal triad in severely injured patients, and explain how damage control resuscitation aims to reverse it. Explain the shift in focus from immediate definitive repair to stabilizing the patient's physiology before definitive surgery. And finally, describe damage control resuscitation principles. Damage control resuscitation is a strategic approach for the most critically bleeding trauma patients to stop the lethal triad and buy time for definitive care. The lethal triad is a vicious circle starting by hemorrhage, and as its name indicates, the three components are hypothermia, acidosis, and coagulopathy. The goal of this approach is to improve survival in these critically bleeding trauma patients. Damage control resuscitation principles are: 1. Operate on physiology, not on anatomy, meaning prioritize physiological stability over anatomical repair. 2. Permissive hypotension. Allow controlled low blood pressure until bleeding stops, avoiding excessive crystal widths that worsen acidosis and coagulopathy. 3. Balanced transfusion. Give blood with all its components, packed red blood cells, fresh frozen plasma, and platelet in a ratio of 1:1:1. Give this blood early to restore clotting factors. The principle number 4 is to administer tranexamic acid, which is an antifibrinolytic drug, and to give it as soon as possible, ideally within 3 hours of the injury, with the aim to stabilize blood clots and reduce mortality from massive bleeding. The principle number 5 is rewarming, by actively warming the patient with warm fluids, blankets, and heated oxygen to fight hypothermia, a component of the lethal triad. The principle number 6 is to correct acidosis by addressing the metabolic disorder primarily by controlling bleeding and restoring tissue oxygenation rather than just giving bicarbonate. The principle number 7, calcium management. Administering calcium during massive transfusion, especially if ionized calcium levels drop below normal, to support cardiac function and clotting. The principle number 8 is the use of vasopressors with certain rules. First, the early introduction of these vasopressors as bridge therapy when life-threatening hypotension persists despite adequate blood product resuscitation. Second, fluid sparing. In fact, one potential benefit is that early vasopressors can help avoid the harmful effects of massive crystal width or fluid overload by maintaining pressure with less volume. In conclusion, damage control resuscitation is about staging care, correcting the lethal triad with balanced resuscitation. And as a reminder, lethal triad means the coexistence of hypothermia, acidosis, and coagulopathy in severely injured patients. The benefit of this approach is to improve survival rates in severely injured patients. Now, we can say that we mastered the lethal triad, but we are neglecting the lethal diamond. Join me in the next session as we explore why calcium is now considered the fourth cornerstone of trauma survival. Thank you and goodbye.